Good morning. Everybody can hear us and see us from Mount Sinai. Welcome to this live in box recording of a case for India Valve uh, 2023. And myself, Samit Sharma, Dr. Sahil Khera on left side, Dr. Kini, and Dr. Gilbert Tang. And then we have two fellows here, Dr. Supawat and Dr. Rajiv Samtani. So, and there are a lot of other team members, along with our anesthesiologist Rafael, and on echo, Dr. Stem Larakas, and a lot of other, nurses, technicians, and so we are ready to show that case. And I welcome all three of you as the moderator with Praveen Chandra. He is a director of cardiology and cath lab at Vedanta, the busiest center in India. Then Prashant Dwivedi, our old fellow and now back in full action at ESCC as a director of structural heart intervention, and Dr. Pedro Moreno, my colleague here, who actually does moderate our every 2 months structural cases, and is the director of quality and performance improvement. With that note, we want to show this case, and I know, Praveen, you have all type of cases you have seen, and I guarantee you this kind of case you have not seen. These are all which we have shown here, and the additional moderators have shown. This will be a TAV in TAV with a 29 millimeter Sapien Resilia valve in a 34 millimeter Evolute R, which was done about 7-8 years ago and degenerated, and RCA protection. Why I said, Praveen, that case-wise, because this has so many things happen to this patient, structural point of view. This is the patient presented with dyspnea and exertion with recurrent symptoms. Jehovah's Witness had a bicuspid aortic stenosis at a tower of 34 millimeter, then generated bioprosthetic AS, had a BAV with 26 millimeter Sapien balloon in 1122. At that time, they tried to put a stent in the ostium, could not, just did the balloon. Then patient also had a severe MR requiring TEER with mitral clip and did good, ejection fraction 25%, and of course CKD, and now showed recurrent severe bioprosthetic aortic stenosis, and patient is here now with a TAV in TAV. So already have few procedures, good medical therapy, as you can see, frequent PVCs in the terms of the EKG with normal sinus rhythm, and AS, which we are going to show, coronary point of view, non-obstructive. So we'll want to show the actual echo. This is the echo which was done a few days ago with EF of about 20%, severe prosthetic valve dysfunction with both gradient as well as regurgitation, but we can show the live feed from Dr. Stem Larakas.
Thank you, Dr. Sharma. Good morning from New York. I have on my left our two structural imaging fellows and our structural imaging sonographer. As you can see, very dilated left ventricle. This is deep gastric images, very dilated and very severely hypokinetic with ejection fraction of about 20 to 25%. This is the long axis, deep gastric images. As you can see, again, the same very depressed LV function. You can appreciate the clip in the middle. This zoom image around the clip, only mild residual mitral regurgitation. And again, this is another zoom image, no significant MR from the clip. And the gradient, mean gradient through the clip, through the mitral valve is 6 millimeters mercury. This is the right ventricle, very good right ventricle. You can appreciate the tricuspid valve in the middle. And this now is the mid-esophageal images. As you can appreciate, the bioprosthetic aortic valve severely degenerated with severely calcified and thickened leaflets with decreased motion. This is an X-plane of the long and short axis. And also you can appreciate the dilated proximal aorta, which measures 4.8, which goes again together with the history of bicuspid valve on this patient. This with color now, the same X-plane image of the aortic bioprosthesis. You can see only mild central aortic regurgitation, and I will show you more images that show no PVL, which is important for these cases. This is a deep gastric images of the aortic valve, X-plane. Again, you can see the thickened leaflets, decreased excretion. And this is with color, just to show you that the AI that we see is central, valvular aortic regurgitation, mild to moderate at most, but no PVL, as you can see on this patient. The mean gradient that we obtained here today is 21 millimeters mercury. The gradients that were obtained in the previous echoes were significantly higher, with the mean gradient that the maximum that we got was 46 millimeters mercury. This is the pulse wave through the LVOT. And by putting all the measurements together, the aortic valve area comes to 0.8 centimeters square. And by putting together the BSA stroke volume index is 33, which is consistent with classical low flow, low gradient aortic stenosis. And this is just for the coronary flow. We can appreciate very well the left main, and with coronary flow color Doppler, you can appreciate the left coronary vein, the left coronary artery, and with the flow. Thank you very much.
All right, oh, great. And of course, we'll take the comment from all the moderators, but let me go a little further. Go back to the slide presentation. So clearly, degenerated, more stenosis than regurgitation, right? I mean, that's basically with the severe LV dysfunction in this particular case. And then they last time patient had coronaries left-sided, you saw it. Right is issue against the stent frame about node 4 of the evolute valve. So both of you, the Gilbert and Sahil, comment on this node 4, basically what it means.
You want to take that? And
Well, we'll talk about that. There are a lot of slides to show you actually, but essentially what we discover with the evolute valve, which is a supraannular valve, you need to position this for TAV and TAV, a sapien 3, just below the right corner in this case, because the stent frame is right against the orifice. So when you actually put the second valve, remember the first valve, the lever is going to pin up. So if you implant too high, so this case we have to position a little lower to avoid that happening. So that just first to visualize where the right coronary takeoff is, and of course we'll show you live in a moment with Dr. Sharma, Dr. Keeney, and Sahil. Next slide.
So basically, the two both actually, because it's a patient of Dr. Pedro Moreno, but for both Praveen and to just and Prashant, that this is the one big concern is when you put the new valve inside, and we know coronary obstruction is one of the always the issue of the valve in valve, or whether surgical valve or you tower in tower. So that is one of the big issue, and then therefore cardiac CT was done at that time. This is and this is basically showing off various points. Anything new in this?
No, this is just to show the frame expansion, which is important. If you talk about whether the second valve will expand further, that's some of the work done by Vancouver. That with the balloon expandable inside self-expanding, the frame will expand further. So actually, the coronary obstruction risk may be higher than you think. And this is just a measure to determine, what size valve and what type of valve we're going to put in. Next slide. Let's just go for it. So you can see that's where the white coronary take off, and you can see the frame of the evolute just right against the orifice. So that's going to be causing obstruction because now the sealing skirt of the inner skirt, but also the leaflet itself, because of supraannular valve, remember, is going to go above that, and that's where it's going to be a problem. Next slide.
And because of that, last time when patient presented with heart failure, before patient got the tear, they said, let's just do a BAV. And as you know, there are a lot of papers are coming now. Compared to, we say, used to wait for the final degeneration of the surgical valve, that intermittent BAV in the patient, so don't let the valve degenerate to the final level, particularly in the tower valve. This is something new concept which is coming. Actually, it's also part of the complete tower. They will do a yearly hemodynamics, and if valve start deteriorating, you get a valve, then you do a balloon valvuloplasty of those cases. So that is being incorporated. Aortoiliac bifurcation is simple, and aortic arch, anything, Sahil?
No.
Nothing. Okay. So let's keep going. So this is in November of last year. So this is, as you can see, they just did a balloon, the valvuloplasty using the Edward balloon. So which is a 26 millimeter sapien 3 balloon system, dilated, and they injected at that time to see if the right coronary fills. Right?
Yeah, and then it was complete. There was no flow in the right corner. You can see the left is filling.
Yeah.
I think about the node, one thing we should also mention is the RCA takeoff is very important. It's an anterior takeoff. And that sort of helps us where you want to deploy your second valve as well in this case. Because you cannot, we used a 26 balloon thinking we're going to probably end up using a 26 valve. But had we thought about a 26 valve and deploying it at node for a lower position would have probably led to an LV migration with time. So something to think about, not just coronary takeoff, but also where you want to deploy your second valve.
Beautiful. So this is BAV done, and patient did good. Gradient decreased to about 10 to 17 with a trace AI, and final aortogram, as you can see here. They had a wire protection, but they thought that maybe they will be able to put a stent. They could not, but overall no regurgitation and patient did fine. So at course after BAV, 6 months after that, patient continues with recurrent heart failure, requiring hospitalization, and now AS is not that bad yet, but now has a severe secondary, moderate to severe secondary MR. Then after discussion, decision was made to do a TR. And this is what done. Anu did that clip. Actually, one clip almost obliterated the mitral regurgitation. Right, Anu? Is there MR right now even today?
A mild MR.
Mild,
Yeah.
mild.
Yeah. No,
The clip is doing a good job.
so
yeah.
mitral clip was done, everything good, and this is now echo again showed now significant degeneration. That is what latest we saw it of the 34 millimeter evolute R. Now we try to, when we selected this case as our the India valve directors, the question is, should we be away showing these kind of cases, the tower degeneration, which may put negative word about this technology? No, I think because these things going to happen. Because longer we follow these patients, this will happen. So I think this was the right case, and we actually have shown about 3 of our live transmissions from Mount Sinai, where we show the tower degeneration and got another tower valve. So this is echo. This already has been shown. We just go to the next value, and this is where I'll ask our expert, who is part of the paper, is valve selection for tower in tower. Gilbert. This is your
Yeah,
associate
so
in
what
that.
you can see here for tower and tower, you don't need to look at in terms of not just the second valve, but also coronary access after the second valve. So I think in terms of where the position is. So next slide will actually show you some images about that. So what we do in our workup is to look at, this is a 29 valve position at the bottom, and you can see how high it can go. And what you're trying to do, all this measurement, you determine where the ceiling skirt is, where the commissure is, where the left main might be taken, and you look at the right side of the screen, that's the right coronary. So you really want to position the S3 right below the right coronary, because we're going to protect it. Otherwise, you're going to cover it up, and you're going to cause coronary obstruction. Next slide. And these are some of the slides that show from the Vancouver group, the paper, about where you're going to talk about no 4, no 5, and no 6. No 6, you'll pin the leaflet of the evolute completely, but no 4, you will not. And there's some concern about what we call the overhang of the first valve leaflet over. But there'll be an abstract coming out in TCT from the same group that we're part of that show that it's not as bad as people think in terms of the leaflet overhang. Next slide. So we do by floral calculation. So this is a very nice slide prepared by one of our fellows. If you look at the no 4, 5, and 6, that you cannot put the valve in no 3. That's too deep of the second valve. But no 4 is the first no that you can see, and that's where the right coronary takeoff is. That's shown by the arrow, and you'll see it on the angiogram shortly. But if you go higher, you're going to risk coronary obstruction. So because of that, and this is a 34 evolute, you cannot put a 26 in there. You're going to have, as Sahil mentioned, migrate in the ventricle, because you have to seal against the bottom inflow of the evolute as well. So that's why we're going to use a 29 in this case. So.
Yep, 29 only. And so this basically, as we have presented this, it's a tau in tau and degenerated 34 millimeter evolute R, where we put a 29 millimeter and Resilia what we are using because of patient's age, which is Resilia basically is the long-lasting leaflet, and hopefully because surgical data are very positive, and we are using that. And it's not a case for sentinel protection.
We have a sentinel.
Sentinel, okay, sentinel cerebral protection already has been done. And with that note, Praveen, we ask you comment on this very difficult case, and we'll start now actually performing the procedure now. Initial will show, Anu will show some pictures which have been taken with the aortogram and so. But just comment on this case. Now we can go back. Slides are done. Let's go back to the live, all the moderators and so. Yes, Praveen.
Yeah, okay. So first of all, I must congratulate the team for taking up such a unique case. And I must say that nobody must have seen this ever, that putting a Resilia, this new valve in the self-expanding 34 millimeter size valve. So there are a few things. And of course, you mentioned that the valve to coronary distance was extremely low in this case. And usually we take a, distance of, the safe distance is 4 millimeters. And here you have almost no distance at all. And plus it is, the expansion of this waist will happen when you put a 29 millimeter valve in that. So the waist which is looking small now will become big. I think that is the contention which Dr. Gilbert was also proposing.
Yep.
And the third thing is that we have to do. I don't know whether you are going ahead with the coronary protection or not, but it appears that probably coronary protection has to be done in this particular situation. And we have done a few TAV and TAV cases now, because you said rightly that this is going to happen, and it is happening.
Yeah.
We have done self-expanding, in a self-expanding, and a balloon expandable in a self-expanding also. But I think this is a perfect, nice idea that you are doing today of Resilia in this self-expanding.
Beautiful, beautiful comments. Prashant, anything from your side?
Yes. Good morning, Dr. Sharma, Dr. Kini, Dr. Tang, and Dr. Sahil. It's really a pleasure to see you all. And no doubt, it's really a very interesting and very complex case for tower and tower. And the way you have shown that there is a very low takeoff of the RCA, there is very low distance of wall to coronary distance. So this is going to be a challenging case, and no doubt here we need some coronary protection, either protected with a balloon, or we might need some basilica. So I think the protection with the balloon or might be a stent would be a better choice here.
Beautiful. Okay, Pedro, comment from you, and then Anu will show the picture, and then we start.
Yeah, very important case, as we did the balloon aortic valvuloplasty, and we saw that the RCA at that moment got occluded. The patient had heart failure with reduced ejection fraction before the first TAVR with a very low EF that normalized after the TAVR. Of course, now with the dysfunction, we are facing the same problem, and his life expectancy is severely reduced. So no questions asked. After family meetings and all these, the procedure must go on, and we are, as a team, all together with, as I said, with the patient and the family, Jehovah Witness also. So let's go ahead.
Beautiful. Anu, tell us what's happening, what you did so far.
So let's go to the fluoro. This is the aogram.
Yeah, seeing it.
Okay, good. You can see the single clip. You can see the aogram, the takeoff of the RCA. As the discussion has happened, low height, anterior takeoff. So what would we do in this case? So this is where we are with the guide and able to free wire, but the issue would be the same. We definitely have to protect, and the protection will be with the stent. Normally what we would like to do is leave the guide and then leave a stent, but in this situation we will need a Godzilla or a guide liner or extension into the RCA. We fear that the guide will move as we are trying to get a sapien valve into this current tower valve. So how do you get that? Is you go ahead with the balloon, you balloon anchor and then extend the Godzilla into. So this is where we are now. The Godzilla and the stent is in the RCA. And how do we cross this valve? So we always teach in the native we will use AR2, but when you have to cross a tower valve you need a pigtail. And this also we have shown all these steps probably in our animated app. So you see there, it's very safe way. Pigtail just above the valve, and usually many times pigtail will just go by itself. If not, use the wire support so that the pigtail will get into the LV. You don't have to be too aggressive. Make sure you're in the lumen. Coming to the lumen. Wire.
Yep. And show the
Manipulate.
hemodynamics also in the one side, please.
And then that's how the pigtail goes in. Yeah. So now we have the pigtail, and this is where we are with the hemodynamics.
Yeah. Significant gradient SM 50 plus. Okay, let's start. What is the plan now? Put the valve, right?
Yes.
That's the plan. And we already have protected with the stent there in the mid RCA.
Gilbert, do you think we need to do BAV or just?
No, I think we can go straight ahead.
BAV has been done already.
That's right. Yeah.
Yeah, that's a very good point. I mean, it's not a very degenerated valve.
Just to see the movement again with the guide and the stent.
No, I think we go.
No,
with
I mean,
that.
if in the native, remember when we are doing a protection, we always
the
try
cover.
to do a BAV.
No, but not in this
Yeah,
case.
not in this.
You're done
Yeah,
it.
good.
Just
Because
see-
the way the pigtail cross, that's another sign that you probably don't need a BAV.
No, so the other thing is, the point here is that when we do a valve in valve, or so same principle we might follow here as well, that
on.
we don't need to really do a balloon dilatation,
Yeah, yeah.
because the degenerated leaflets may kind of have some kind of a break off or something like that. So maybe it's not required.
Well,
Good.
However, you still have a sentinel protection.
Yeah. So show the sentinel protection by fluoro. So that it's recorded there. Above.
Yeah.
Go to sentinel 1
Fluoro.
second.
We have a floral view actually.
If, hold on. They have a, hold on.
No, nobody showed
all
it.
the way up. Yeah.
Who has the fluoro?
That's
Yeah.
it. Yeah.
Sentinel is.
Okay.
We know that the valve in valve, tower in tower, they have high chance of
Yeah.
embolism and CVA. So we try in every case possible. At present, we are using in about 60% of cases. But again, we did not decrease. I know after the Protect trial, they felt that they will go down. It remained the same for centers which are using for TVT in the USA, still around 18-20%.
do two.
But we are
Usually
still about
29.
same. Maybe we're a
29,
little
two
selective.
inflations.
We used to be like 62. Now we are about 50.
Okay. Okay.
Push
Do
the
it.
wire. No. hold.
Right. Okay.
Push the wire.
So because in India, particularly, actually what happened was, then when we started the Sentinel device, within 1 month, this product trial data came
I know.
in. And that is why
Yeah.
the takeoff was stunted.
Ready?
completely.
Okay. One
That's true.
moment. Okay. Okay. We are going up. Get the wire back a little bit.
Okay. And
Who's had the wire?
Somebody holding the other.
Somebody hold the wire.
No, okay. But is somebody holding the catheter? Other?
Go.
Gilbert holding the other
Not
catheter.
your,
Has to be
I
careful.
have it, please.
Okay, good. Okay.
Talking about the
So
guide.
this is the time. that-
Wire.
Go.
Yeah, wire is
Pull
good.
back. Pull back.
Yeah,
It'll
yeah.
flex. It'll flex. In.
Yeah, yeah.
Good.
No, but now we have to be careful at this time because your catheter may.
Just give it a second. It'll drop.
Yeah.
Okay.
Give it a second. Take some flex off. It'll drop.
Okay. Remove the
Yeah,
flex.
that's it.
Good. You saw that interaction of the guide catheter. We actually
Now
have.
push it down.
Gilbert, hold,
in now,
hold
go
this
in
one.
now, go
This
in
one.
now.
I know. Hold the
Yeah, it'll
guide.
go.
Okay.
Yeah. All right.
Yeah,
That's perfect.
So let's unflex.
You unflex fully.
Everything's fully.
Okay, can we mag in now to the valve and center the valve?
Yeah.
Good. Perfect.
Good.
So it'll go lower. No, so
Okay.
it'll go
You want to take a
lower, no.
picture?
I would
No,
go a
we
little
let's
lower here.
position the valve first. It's going to be the top of the valve needs to be a
yes.
no 4, right? So we can count.
So let's go
So
down. a
go
little bit.
down further, please.
Yeah,
good.
that's
A
it.
little bit more. Yeah. It's
Little
no
bit
4.
more?
Yeah,
Little bit
because
more.
the count 1, 2, 3, 4. So below the gut. Yeah. Below the little bit more
One,
because
two,
yeah.
three.
Yeah.
So
Take a picture now.
we
Sene.
can,
No, I think we are 3 now. Hold on.
Now, let's see.
SS, wait, we are in the guideliner.
Ready?
Inject.
We,
Or
we
not
are
No,
we're
no,
in
no.
the
Hold on,
guideliner,
hold
yeah.
on. No need. No need.
Okay, then no injection. Okay.
Yeah, so Dr. Chandra's point that the waist will expand, we're trying to deploy lower than that. So that's why we're using a
Doesn't come
29
up, huh?
here.
This is correct now?
1, 2, 3,
Yes.
4. Yeah. No high.
Very
So
good
you're a little bit
concept, but
higher.
you go
I would
for
start a little lower.
Yeah.
Let's see.
Go lower.
Go
Just
lower,
a little
one
bit,
dot
little
lower.
bit, little bit lower. You're almost there. You're almost there. Just go,
so it
go
will-
that cross. Can you move a little bit?
I'm going down.
Sure.
Okay,
That's,
good.
that's it. That's
Good,
it.
good,
Yeah,
good.
that's it. Yeah. Make sure it doesn't come up. Make sure it doesn't come up.
I
Good.
don't want to touch the other guide.
The
Let it
balloon.
stay the way where it is, right?
Yeah. Make sure it doesn't come up, huh? No.
No, I won't come. It won't
Yeah,
come.
because it's,
Why
it's
you want to
canted.
hold
No,
it?
it's
Let me,
canted.
one
It's
by one.
canted, that's
I
why.
can tell you, if you
It's
want, you can
canted.
bring the guide liner back into the catheter. We can inject now, just to
I'm adding
document.
Little flex here. You're good.
Put the flags. Okay.
Yeah, that's
And leave it there. Leave your left hand and take the guide liner back out. Or you want me to come there?
What guideliner you want out?
Out so we can take a picture that we are all good position. You want to just document? Yeah, that's okay. We can do that. Okay.
Actually,
I think
this
you
is
should leave the
this is
guidelines.
this is a good,
I would
this is a
not
good
touch
position. Yeah.
anything
Okay.
right
Just
now.
push down to
Yeah,
node 4 and
We
we're
will
good.
lose
Guideline.
what we achieved.
Yeah.
Okay, good.
It's a
Little
little,
bit
it's going to ride high. So just come down a little bit more.
A little bit more.
It's going to ride up.
Yes,
Yeah, that's it.
yes,
That's it.
yes.
That's it.
Okay.
Just go
Yeah.
slow. Go slow. Yeah, go slow and keep it there in
Who
that
has
position.
it?
I have it.
Okay, good.
Base 180.
Yeah.
Just Sine once. Sine, okay. And off pacer.
Okay. Yeah. So that's so you can see the no 4 is right there. where the top corner of the
Yep.
sapien
1, 2, 3, 4.
is,
Yeah.
right? So you can count.
So we're
So,
deploying now.
so we want
Okay,
to go
good.
slow and
180.
make sure the valve does not go
Pace
hover.
180.
Okay, go.
Yes.
Oh,
Oh,
went down.
Keep pacing, keep pacing, keep pacing. Pull up. Off pacer.
Inflate again. Inflate again. Inflate again.
Inflate,
again.
inflate,
The pin,
inflate.
inflate the pin.
Go in. Go in.
Pin,
Go in.
pin. Okay, go.
Go in.
No,
Little
go,
more.
go in the balloon.
Pace
Go.
180.
It went
No,
down.
no, go in
Completely
balloon
went
more.
down.
Go in balloon
More
more.
Good.
Okay.
Yeah, go.
Going up.
No, it's in the LVOT.
Pull back.
Because the LVOT is big. So
Off pacer. Let the patient cool off. I would hit here in the middle.
It's too bad now.
No, we need to put a second valve.
Let's see. If you can get in.
It's going down every second.
No, it's not. Okay, come down with the
No, see, went down.
okay.
prep a valve. Bring down.
Balloon is not going.
Balloon. Bring the balloon down.
No.
See that?
I think we
What
come
do you
out. Come out.
Color?
Okay.
Undo.
See that too. No, it's coronary flow. See.
So definitely it has gone down to node 2 instead of node 4, right?
Yes. Note 2. But let's see how the
Come out.
hemodynamics looks.
No, this is
Coming out.
No.
this is in the LV. What do you think,
It's
Gilbert?
a pretty dilated LV. So
We need
let's
a
see.
second one. We need a second one.
I think we need a second valve.
Yeah.
Yeah.
Tam, what does the T show?
Give 1,000 more happen.
Because the valve that you just placed is good. As you can see here, but
Is it the below the leaflets of the?
Yes.
yeah, it's
Yeah,
below.
you
It's
can
below
see.
the. As you can see there.
Show
in
that
the
echo in the main screen, please.
real life T transophageal echo. You see the new valve that is proximal to the previous valve, functioning well,
Yeah, we
but
can
the old valve is. I mean, this as was before with severe actually now regurgitation. So there are. I think we have to put an.
So clearly, right, we have to put another valve there.
Yes, because we have to cover the leaflets of the
Only
original.
question is in this process, what if this sapien valve embolized downstream? Can it
I
go?
don't think it will.
I think node 4 was too low. It just went down.
It is hanging with the lower end of the first valve, so it still has some kind of anchor. And when
Okay.
you put the
Yeah.
third valve, it will put these
See
two valves
fluoro?
together.
See the fluoro?
No,
Just
that's not. That's
Cine
not the
fluoro
thing.
cine. So we have it that. Cine.
Cine.
Can we get the valve, please?
Not getting it. Gilbert, any comments?
No, I think the valve is stable. I'm not
Okay.
worried about that. I
I
think
see.
the balloon is so big over to the
Yes.
waist. Remember, the waist of the 34 evolute is a 24. So it pushes down because there's no LV support. The LV is very dilated.
Yep.
So I agree with Dr. Keeney that we'll start a little higher and then just slow inflation to adjust with the expectation it's going to go deep again. So I think we can maybe
No.
start at no 5 and no 6.
Smaller valve.
But the smaller
Yeah.
valve is going to be problem with anchoring. I mean, we can do
No, 29 1 minus.
No. We have the balloon. The problem is the guide and the balloon of the sapien interacted and it just went further down.
Because it started pretty well
Can
at
we do?
node 4 here.
Yeah. But as you inflated you. No, the question. That's what I'm saying is that we cannot move the guide. If we go back with the same thing,
So that's
We
a
have to
good
be higher.
discussion point. Would you do a 26 now instead of a 29? Because given what you saw happen with the
that's what I
with
would
the
do.
balloon movement, Praveen and Prashant.
Yeah, so as we already know that the waist is small, and what happened visually, which we saw, that it actually pushed the whole thing down because it is a smooth internal surface of this the evolute valve, the framework, which pushed it down. So I think choosing a 26 may be a better idea than 29. Or
Okay,
if you have to do a 29, then you have to be a little higher, and then only it can happen. But the problem with then it'll be that it'll lead to more, this one, the chance of a coronary obstruction. So we can't go too high. So we have to choose a 26.
Yeah, so
Okay, why don't we do a 26 plus
26.
3? Okay.
26 plus 3.
Yeah.
Now, other thing is, do you want to do 26 deploy, then next second round,
Post
well,
dilate.
plus 3?
Post dilate?
Yes.
Yeah.
I
I think
would-
that's a
Right
very
now the
good
balloon.
point, because initially also we were actually debating the
Yeah,
two
it's
choices,
26.
and we had a lot of discussion about where we want to deploy, and 26 plus 2 or plus 3 was
Plus
one of
2.
our initial valve choices.
And we
before
go back to
decided
that
on
now.
26 would be okay or no?
The concern, Praveen, at the time, Prashant, was that with the inflow of the evolute, if you saw the CT, the area was 666. It's definitely in the 29 range. So there have been reports of actually my LV migration when you pick a 26 inside a 34 if you don't implant high enough. Like the waist is 24 of the evolute 34 is a 24, right? But the inflow is 34. And in this case, it's more like a 29. So because of that, that's why we decide on a 29 valve. And also you may run the risk of paravalvular leak if you end up using a smaller valve. So what we plan to do here, now that the 29 is in, I agree with you that I think it's reasonable to do a 26 this time, because the 26 will be implanted inside the two frames essentially. So you should now have better anchoring.
So 26 is okay, plus 2?
Yes.
No, no. I think, is it okay we deploy 26 nominal and then second round we go plus 3?
No.
I think
I'm
we should
worried that
it'll move.
balloon will again
No,
slip it.
it'll move.
But you can leave some volume
Plus
behind
two,
if
yeah,
you
let's
like.
leave volume behind.
You can
yeah.
look for volume. We put prep it as
I think
you go
AK
and you
has a
see.
very,
Get a
very
26 quick.
good point. She said that go with slightly lower volume up front, and then see how the balloon behaves because of the guide interaction. And then you can add more volume once you have anchored the valve there, just to give it more flair.
Good.
I think that's a good point.
Okay.
So Sahil, actually, you can fill up with 3 cc extra.
Yes.
Go
Because
while you are inflating,
Nominal,
you will know
and
what's
then-
happening. Then you can decide at that time.
Yeah.
What do we have? We have Regelia Ultra. What we have?
No, check that. Explain.
So just did a Synate. It is
What
pretty
are your?
stable. You can
What do
see
you have
hasn't
at
moved.
present here? 29 and what else? That's it. The 26 valve is there. Now we need the delivery system. Okay. All right. It's
Some PVL between the old and new.
so now we have to be very careful now that where are we going to
No,
start?
can we? What happened?
This is the key.
Right.
I would
At
go
the
with
level
the-
of the guide catheter now.
Yeah, at the level of
level of
guide,
guide,
and let it maybe come
absolutely.
down. And if it's not coming down,
It's
then you
between
can
the
just
the two
make
new
some
ones.
adjustment.
Very, very interesting and very educative.
Yeah, I think Praveen, these patients are very complex, and this one has such a dilated LV. There's no support from the ventricular side, right, of the ballooning standpoint. So there's a path of least resistance, as you know, and the waist of the evolute is 24 only. So it's a 29 balloon against a 24 waist. I think that's where the challenge is. But I think, with a smaller ventricle, a normal ventricle might be different in terms of the dynamics of the inflation.
Okay, we got our equipment ready. Yeah, 26 Commander delivery system has arrived.
Yeah, remember in TVT registry, I think last year we did over 80,000 TAVR in the United States.
Yep.
0.5% of those were TAV in TAV, and that's not even including, that's including actually any acute same implant. So it's very, very low. We are all learning these procedures. We screen these, and there are no, still trying to come up with any consensus. Vinny Bapad actually is going to come up with an app later this year. So hopefully they'll give us some guidance on how to size, how to position. Any kind of strategy, because sometimes these valves are underexpanded, you know. So do we need to post dilate afterwards? You know, because these valves we know it's not like surgical valve, we can't fracture, right? So we have to basically try to optimize the expansion. So yeah, so there's a lot of learning pieces, moving pieces in this field that we're still trying to get an understanding.
And not to underestimate the effect of selection bias in the registries that have done redo TAVR, because these are carefully selected patients with meticulous CT planning and at higher volume sites. So you don't have all comers going through it. So it does not really reflect what complications you can have or what's the outcome of these patients.
No, but TVT registry has all comers.
No, TVT does, but
Yeah.
redo TAVR and all those that have shown, it has a big
No,
selection
Sahil
bias.
is correct. So, for example, in Uri Landis registry, there's no coronary protection in these patients. So, you know, this case would definitely not have been included in a registry like that, because this would have considered anatomically unsuitable for TAF in TAF. So it's not been discussed about any adjunctive techniques to manage these patients and manage these kinds of anatomies.
2 cc's
Tang,
extra.
one question.
So was there any thought of doing a basilica in this situation?
No, it would not have helped, Praveen, because remember, it's the frame of the evolute, because it's a bicuspid valve, right? The frame of the valve is buttressing against the right coronary. So even though you split, you have to go all the way to the base. But remember, this one is like, even with some commissural alignment, you still need, it's about the spray of the leaflet after you deploy the second valve. So some people talk about balloon-assisted basilica to that. And of course, you know that the right coronary is notoriously harder to do split. But I think, you know, technologies like shortcut, where it's more mechanical and can see it more easily, may be easier to do. And so far, I think the early feasibility is almost completed. So we'll see how it goes in terms of the results.
Prashant, you have some question?
Yeah, so Dr. Tang, what are the conditions where you prefer tower explant as compared to redo tower? So
Sure.
no doubt
So
this patient is without a high risk, so it can't go for the tower explant. Its only scenario is the redo tower. But what are the other conditions where you prefer to go for a tower explant?
So based on our publication, one condition that we cannot fix is severe PPM. So if you have a ton of TAVR and you cannot, you have severe PPM, especially with a self-expanding valve, then you really don't have other option.
Yeah.
If you have a balloon expandable valve, you can potentially treat with a supraannular self-expanding valve like the Evolute, and we have done that actually in the past, and that has actually worked. But you have to make sure you don't have cause coronary obstruction. Of course, with explant, you have to be a surgical candidate as well. And you saw that the mortality rate and the morbidity rate are still very high. As surgeons, we're still learning these procedures, these operations. We're trying to come up with a consensus to simplify these operations. But also, a lot of times, these patients come in with other issues. Not just the TAVR issue, but also they have now severe MR that you cannot do a clip, for example. So now you have to basically do the surgery of fixing everything.
But clearly, the explant registry did say that at least for the short term, the TAV is better than the surgery. Mortality of 3 versus 14% at 1 year. Outcomes were similar, but slightly lower mortality. But those are the very selected cases. And so, okay, so we are ready with the 26 millimeter plus 2, and let's take the part 2 of the show.
So valve is very stable. You can see hasn't moved at all, hasn't migrated. But late migration is a real issue, and
So
especially in patients with large LVOT.
Just from echo point of view, there is a lot of PVL between the new valve.
Oh yeah, but there is a clear-cut gap because nothing is covered there.
So now this third valve will hold these two valves like a bond.
Let me go 1 second. Yeah. Go.
Yeah.
One low mag. Go.
Yeah, fully flexed.
Yep.
Yeah. Good. Good. Taking some flex off, it'll straighten down. Little more. Yeah.
Okay. No, we still should go with the relative to the guide location.
Yeah. Guide is good.
Yeah, guide is good.
Fluoro. Yeah.
So your guide is good.
I think looks good.
Yeah.
If you try to adjust more,
Yep.
I would take the parallax off.
No, no,
on
no,
the,
no, 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 no. The evolute. Yeah, perfect, right there.
There.
Yep, good.
Sine, before you go on.
180 and cine, please.
You want to start higher?
Slightly
Start
higher.
higher. Start higher.
Off.
Yeah, yeah, yeah. Let go of the guide. That's fine.
You want to pull back a little more?
Pull back a little bit more if you need to. Yeah, you pull back a little bit. Start a little bit higher, and then you can just slowly adjust.
Good.
Yeah.
Yeah.
Okay.
Base 180.
Stan, do you see it?
Yes, I see. Yeah, it's maybe if you want to come a little bit more aortic to cover a
Push
little
it
bit
down.
more.
So very slow
Okay.
inflation.
Hmm.
Little more. Push down. Good.
Oh,
Pull
it
it up.
came out.
No, I'm not
Oh,
going.
oh,
I'm
Came
not
out.
going.
Came-
Yeah.
Mm-hmm.
Go up here. Go up here.
Go, go.
So you can see micro adjustments.
Good.
Yes.
Perfect.
Mm.
All right.
Much better. Much better.
fantastic.
Off pacer, off pacer, off pacer. Long pacing run. I need some anesthesia. Good. Just wait there. Let the rhythm come back.
And show the hemodynamics also.
Yeah, the pressure is coming up.
Beautiful.
Now this looks to be a very perfect situation, perfect placement.
Yep.
Yeah.
So much adjustment. Wow. Whoa.
Yeah.
So you see slow inflation was key and micro adjustments. You were seeing how we were, AK was making
Yeah.
these micro adjustments.
And how much volume we pushed
the
in?
most important
28.
was 26 selection.
26 plus 2.
Yes.
No, no, we went first to just low, and second time we went.
We'll go higher, yeah.
That's the way. Now we have to go up again.
Okay.
That's why we need.
Stam,
Yeah, it looks
Thank
great.
you.
Okay.
Great.
Okay, fully flex.
Let's
No,
move some
fully
velocities here.
flex. Okay,
EKG
now-
looks good.
Yes.
Yep.
Beautiful.
Very good.
Okay, now you go full.
You got that into
You want to
hemodynamics?
go 2 or plus 3?
What?
We are
plus
plus two.
Did you empty last time or no?
Completely.
No, no. Do you want to put? I think
One
I
more
should put
CC.
one more.
One more.
Get me us one more CC. No, let go. You're full of air.
No, that's okay. No, yeah, it's
PVLs.
No, here, here.
Add here. Be better to add in the.
Oh.
Oh.
That's okay.
Good.
Yeah. Good.
good. Okay. Let's do it now.
So
Go
first
again.
3-3.
Yeah. That's okay. We're good.
Going up.
Okay, go. Now full.
Very good.
Good.
Keep pacing. Keep pacing. Keep pacing. Keep pacing.
Okay, slow.
Off.
Okay,
Off. Off.
Pressing.
Beautiful.
good. I don't even think we need
Beautiful.
need to stent it. Let's see.
We'll
Come
see.
out.
Let's go down on the.
Take the wire
VSI.
out.
No,
do
wire
you
out? Or do you want hemos?
No, we can do hemo. Yeah.
No
Hemo
need.
will be good.
No,
Yeah.
too much.
No, good. Coming out.
Okay, coming out.
So Praveen, you can see the 26 here with the inflow of the 34. So the concern has been if you implant a 26, unless you do it higher like this position, maybe
Ready?
even higher, you're gonna have PVL at the inflow with the 34 and risk of late migration. That's what the concern was. But now, of course, for 29 in a more further down, you're not gonna have that issue, right? So
Big deal.
so that's why I think this is a good rescue strategy as you have suggested.
Yeah. So, so for every 1 cc, it goes with 0.5. So
Yeah.
with 4 cc's, it was like 27.
Yeah, we did 3
28
cc.
actually.
3 cc's. Yeah.
3 cc.
Yeah.
Yeah.
So
So
27
20
and a half. 27 and a half.
Yes, that's what we
Yeah, floor.
expect, Dr. Chandra. But there's also recoil and everything. So
Right, and
But
those are bench data as
Bench
well,
data,
Chandra. So we've done some post CT now. Actually, we published the 2 papers in our group. One in CCL, one Jack intervention. We intentionally undersized with the Sapien 3 with analysts for concern of rupture. And when we do the post CT, actually we showed that the dimensions were pretty much nominal. It was not like a 23 valve suddenly becomes a 24, 25.
Can you re-zero?
It's around 23 and change. It just better
Re-zero,
expanded
guys.
and more
Still
complete
Catalina.
expansion.
No, this is the wrong.
3-0.
Wrong.
So there is no gradient, it appears.
No, we got peak rate of 17 by echo.
No, it's still there. Yeah. You changed the. Why did you change?
Oh, yeah. Some gradient.
Mm.
Yeah, about 12 to 15.
Stamp, what do you have?
17
10.
by Echo
10
17.
here, which is okay.
Peak 17, not mean.
Yeah, peak. So here, I mean, as you can see, the hemodynamics is a bit small, about single digit for him. Always I say, whatever you get on angio, the echo is usually 3 times. So you got 5 or 8, it will be 18 or 20, 3 times usually. On the angio, about 5 to 8, it will be almost 15 to 20.
Yeah, but this is not unexpected, right, Dr.
Yeah.
Sharma?
Yeah.
Remember, we did not pin the leaflets of the evolute upward.
Yep.
That's why, so you still have some residual stiffness from the evolute leaflet. Maybe that's where the gradient come from.
Well,
right,
I
Sam?
can tell you,
agree?
this patient with a
Yeah.
20 millimeters, with a 20% ejection fraction,
Yeah.
we have put a double valve with a long pacing, and hemodynamics is still, with
Yeah.
our help of our anesthesia colleagues, I can tell you it's a win-win situation, even if there is a little bit of PVL,
Yes.
and now we'll decide whether we need to implant the stent as a chimney or not. Okay, let's see it now. How are we doing? You can bring back the pigtail out, and let's take the aortogram with the pigtail first.
Yeah, I agree with that, actually.
Yeah.
Before you do the guy,
Yeah.
let's do the pigtail
Good.
aortogram.
Let's get the aortogram pigtail numbers. 10, 10, right?
Yeah, 10, 10.
Okay, take your TE probe up, please.
Maybe even 15. You want to do it 15? Let's do a
Connect
proper
this,
one.
okay.
Yeah.
Connect this.
Okay.
Yeah.
Good view.
Yeah, this is good. The same. I will keep it the same view.
So we
Okay,
have no
ready?
EKG changes.
Yeah. Good.
Ready?
Not yet. Okay.
Good. Okay.
Okay.
Sine.
Hi.
Wow.
Yeah, the RC is flowing. Yeah.
RCA
That
is
was
good.
good.
Beautiful.
I think leave the RCA alone.
Let's take a picture.
All right, let's
Not
find
about
out
the stent
from
or
our
anything.
referring physician and the friend colleague, Pedro, do we put a stent or not?
No, no,
Remember
take a
last
picture,
time you had a
take a
trouble.
picture.
What did I
Either,
say?
either.
I'll put the stent, not a problem. The stent is there, but do we need to deploy it or not? It was, whole case was Akari 1, guide catheter Akari 1. You needed that and then everything just
Correct.
flew. Yeah,
Yeah, I don't think we need it. You have TIMI3 flow
yeah,
there.
yeah.
Probably a non-selective injection now.
Yeah, she's doing it now.
Or,
Yeah.
Okay, yeah.
So one
Magnify,
of the tricks
magnify.
which I have learned, Dr. Sharma,
Yeah.
Put
Yeah.
back the stand.
one of the tricks I will tell you before you take out everything,
Yeah.
bring the soft portion of the wire, once you are taking out everything, soft portion of the wire up
Ready?
to that, transition. And
Uh-huh.
then take a shot, because sometimes with the
Hey,
wire,
it's so high.
the leaflets are,
Yeah.
so it's nice. It's
Yeah, you don't
Yeah,
need
Karen
anything.
is a-
Just take everything
Yeah.
out.
I think
But I
we're
think
done
looks
here.
very good, my friend. We don't need to.
Yeah.
Remember, in my
Nothing.
paper, in my presentation, I said RCA protection in parenthesis question stent. So I think we just stop there with the RCA protection. If everybody is happy, we are right to the time. Our plan suppose you 50 minutes. We did
Want one more
55
picture?
minutes, and
Want one
we
more picture?
complete
Okay,
the
सब
show.
view?
बारह.
And now actually just have to take out your sentinel. I want to show that sentinel removal also, Sahil,
Yeah,
how
sure.
to do it, because there is India still there is a lot of interest. No, he's saying put the soft portion of the wire back.
In this
No, no, no.
patient,
We are
as this
still
patient is
deciding
having,
whether we need a
No,
stent.
we
or
don't
not.
need now.
That's it.
Everybody
Just
agrees
taking
that?
it. No, we don't need it.
Gilbert,
so
what do you
most
think?
likely you will not, but
Yeah.
take one more shot. One
Oh.
more shot.
Yeah,
now.
we actually did.
Yeah,
we
let's
did.
do that.
It's,
Yeah, let's
everything
show
is
that.
out now.
Here.
How you move this up?
What do you think now?
No, this is okay. But
Yep.
sometimes because of the wire, the leaflet doesn't fall on that coronary.
That's
And
right.
once the wire
Good,
is
good.
out, it
Yeah, let's
starts-
bring the catheter. Let's do with the catheter. No,
That's
no.
right. That
Yeah,
Praveen has an
agreed.
excellent point.
Very important point. Yeah,
That's
let's
right.
bring
No,
back
no,
that
no.
little bit in.
Because the catheter will be holding the leaflet away from the orifice.
Yeah.
That's absolutely right.
Recently I had this issue,
Wanna do
and we
Up,
were very
up
happy.
top.
Everything,
Show the where the catheter is.
everybody came out, and then patient had ST elevation.
Okay, take the pigtail out. Right now your guideline is ahead. Okay. You want to keep that? That's fine. It's coming down now. Here.
Let me go LAO for us to engage.
You're hello. You're good. This is the position we had.
Yeah.
Actually, you know what? That is a very good point. When we take the picture, your wire has to be either soft or completely, because otherwise it may be just pushing it away. Yeah.
Okay, you have the
Yeah.
dye there.
And particularly the high risk cases where you decided to
Yeah.
protect. Yeah.
Yeah, we've seen that in native aortic valve too,
So,
right?
yeah.
Praveen and Prashal.
Yeah.
Right, it looks good, and then
Yes.
when you removed it, and then it collapses.
On the cell above.
Yeah. So this happened in a native valve with one of my recent cases, and we did the coronary protection. Everything was there,
Ready?
and we were
Like
very
that.
happy. Nothing is there. We pulled out everything, and then 15 minutes later, the patient started having
good.
hypertension.
Yeah, looks
Beautiful.
great here.
No, very
Good.
Beautiful.
excellent.
Now take the central out now quickly. AP.
Plugged.
Okay, I think TE should come out so they can show sentinel removal.
Yeah.
We are good, right? With the
T up, please.
Yes, yes.
Yeah. Okay, come help for the central removal.
So it's pretty easy actually. Just
T
pull
out,
the-
please.
T out more. Yeah.
No, much more out now because we are
see
showing
who
to the
has
head
room
now.
one.
Good. Good.
And also
No, it's
tell
still there.
Brian,
Pull up
my
stamp.
patient
Yeah, good.
should go
Yeah.
to room.
So we pull the distal filter back first.
Yep.
Push the mandrel down, takes all the flex off from the system. And then make sure it's straight and nice. And then you re-engage your proximal filter. And the whole system then comes out. It's pretty
Beautiful.
easy. Very
All
easy to
right.
do.
With that note, we complete our presentation and thank you. Thank you all my friends and colleagues.
It was
Beautiful.
one of the most educative TAVR cases in recent times, I must tell you. And we are very happy. I'm very happy that I saw this. Thank you very
Thank
much.
you. Thank you. Thank you.
Bye-bye.
Thank you,
Sure.
Dr.